Hi, everybody. It's a pleasure to be presenting to you in this session on international guidelines for the management of sepsis and septic shock. My name is Mitchell Levy. I am Chief of Pulmonary Critical Care at Brown University and System-Wide Director of Critical Care Medicine and Lifespan. What I'd like to talk to you about for the next 10 to 12 minutes or so is sort of distilling some of what the guidelines are about and offering you pearls to take back home. First and foremost, this is my disclosure slide. I don't have any disclosures for you. This obviously is the most recent iteration of the Surviving Sepsis Campaign guidelines. This is the 2001 edition. We've been publishing the guidelines since 2004, and we've done a lot in the Surviving Sepsis Campaign. Probably what I'm most proud of is the fact of how enduring these guidelines have become and how long they've lasted, and they still remain the single gold standard for the management of sepsis and septic shock globally. So what's different about the 2021 guidelines? Well, I think that this time we placed some greater emphasis on panel diversity, both in terms of gender, geographic diversity, and economic diversity. For the first time, we've included a number of panel members from lower and middle income countries. We've also, the selection of questions have been following international evaluation of practice and uncertainties, and I'll show you more about that in a moment. The PICO questions we added this year, some of the important ones were about long-term outcomes after sepsis, and the use of an evidence to decision framework as a transparent and structured system for formulating recommendations. So this is, we use the a systematic approach to select and prioritize topics for the adult guidelines. What we tried to incorporate were three things: practice variability based on an international survey results, which showed some clinical equipoise amongst several of our recommendations; the panel members' assessment of question importance, so that was the input from the experts; and finally, as we have always done in the past, looking at the published literature, especially randomized controlled trials that have happened in the 4 years since the last guideline development publication. And the final decision was achieved by discussion and consensus between panelists in each group, and the SSC leadership approved the final list of PICO questions. So this is the identification of practice uncertainty, practice variation and uncertainty. And you see here the degree of uncertainty. Look at the first one is, what criteria do you use to determine that an adult patient has sepsis? The most popular answer was SIRS, Systemic Inflammatory Response Syndrome, and yet only 38% of the respondents had that as their answer. The second one, looking at what's your initial crystalloid fluid resuscitation, the most popular answer was 30 cc's per kilogram, and yet only 45% had that. So you can see here, and I won't go through this whole list in the interest of time, you can see here wide clinical practice variation and a fair amount of uncertainty despite the 2016 recommendations, which is actually are listed as the popular answers. So what's new in the 2021 guidelines, and what would I like to leave you with? What kind of take-home pearls? And there are a couple that I'd like to impart with you. First of all, about screening for sepsis. There's no question that with the publication of the 2016 new sepsis 3 definitions, I was a panelist in that publication that we published in JAMA, we introduced a fair amount of certainty around the use of Q-SOFA. And in 2021, our recommendation is against using Q-SOFA compared with SIRS, NEWS, or MUSE as a single screening tool for sepsis, septic shock. And that recommendation strength and quality is strong with a moderate quality of evidence. And that's a new recommendation compared to 2016, because obviously in the 2016 edition, of the guidelines, we had not yet published the new sepsis 3 definitions. This is perhaps this is the basis. This is one of many reviews that have been in the literature about the use of QSOFA, compared with SIRS for the as criteria for the diagnosis of sepsis and the prediction of mortality. And this was published in Chest. And you can see here, in terms of mortality, and this is the reason why SIRS QSOFA was introduced, was because of our ability to predict the value of QSOFA predicting mortality. However, in terms of diagnosis and predicting patients with sepsis, actually SIRS does much better than QSOFA. And this is simply one systematic review and meta-analysis that demonstrates what many of us know, that as we introduced QSOFA, we said for determination and prediction of people who are likely to deteriorate, QSOFA is the best method for doing that. However, for predicting sepsis, still, after all this time, SIRS performs better, as does NEWS and Muse, 2 other scoring systems for identifying infection, than QSOFA. So QSOFA should not be used, as I said already, for screening for sepsis. The next is for initial resuscitation. We again reiterated that for patients with sepsis-induced hypoperfusion or septic shock, we suggest that at least 30 cc's per kilogram of IV crystalloid fluid be given within the first 3 hours of resuscitation. Now, the biggest change for this recommendation was we changed it. It was downgraded from strong with a low quality of evidence to a weak recommendation, or a suggestion, as we now say, with the low quality of evidence. So the quality of evidence, which has always been challenging in the recommendation of 30 cc's per kilogram, has changed from recommendation of 30 cc's per kilogram to a suggestion that we use at least 30 cc's per kilogram of IV crystalloid in the first 3 hours of resuscitation. And I will skip over this in the interest of time. I will say that this is from the PRISM investigators, who were the combination of PROCESS, PROMISE, and ARISE, the early goal-directed therapy data that was published. This was published in the New England Journal in 2017 or 18. And you see here that the usual pre-randomization volume was around 30 cc's per kilogram, the median that is. So this is the source of the current standard of care being 30 cc's per kilogram. And there are a number of ongoing randomized controlled trials that are looking at the value of restrictive fluid resuscitation strategies for resuscitation of patients with sepsis. The next important change in the guidelines for this year was the initiation of antimicrobials. And then this is a bit of a complicated slide, but what I'd like to show you is essentially in patients who are shocked, the recommendation remains to administer antimicrobials immediately. So I'll say that again. For patients who have, when shock is present and you suspect sepsis, therefore we recommend that antibiotics be started immediately and ideally within an hour of recognition. In patients where shock is absent, our recommendation now is if we believe sepsis is possible, then we think there should be a rapid assessment and then administer antimicrobials within 3 hours if concern for infection persists. So shock, administer immediately. For sepsis, administer if you're sure that this is, or if sepsis is probable, then also administer immediately or within 3 hours. This is another new question. This is from 2021, obviously. And the recommendation you can see here is that there is insufficient evidence at this time to make a recommendation on the use of restrictive versus liberal fluid strategies in the first 24 hours of resuscitation in patients with shock. There's a lot of attention being placed with randomized controlled trials looking at the value of restrictive strategies for resuscitation in patients who have hypotension because of sepsis. But right now, there is insufficient evidence to make any recommendation. And so that's also new from 2016. Vitamin C, here, the data are strong enough that we recommend against the use of IV vitamin C. It is a weak recommendation with low quality of evidence because the only randomized controlled trial, which is Victus, was negative, and there are no other good, large randomized controlled trials that in any way suggest the use of vitamin C. Sepsis education, as I mentioned already, this is a new recommendation. We are recommending that for adults with sepsis or septic shock and their families, we suggest offering written and verbal sepsis education prior to discharge because of the large volume of evidence of prolonged recovery in patients who leave the ICU and recover from sepsis in terms of cognitive function and return to work. So we're recommending a recommendation that's based on suggesting offering written and verbal sepsis education for patients. So what are the major take-home points as I close? I think there are a few. Don't use Q-SOFA for screening for septic patients. We continue to recommend or suggest, that should be suggest, to use 30 cc's per kilogram for resuscitation. Immediate antibiotic administration for shock, and if you suspect sepsis, no indication for restrictive fluids, and finally, inform families about long-term outcomes. So with that, I'll say thank you, and I look forward to possible discussion if that's available. Thank you.
Hi, my name is Krista Shore, and I'm a clinical nurse specialist at Cooper University Hospital, and I'm pleased to present the nursing perspective of the Surviving Sepsis Campaign guidelines. My objectives for today are to talk to you about the implementation of the guidelines and how that impacts nursing care, as well as how you can apply this information to direct patient care. So I'm basically going to give you some helpful tips. I won't be able to cover everything in 12 minutes, and I'll also highlight some of the new recommendations and how that applies to nursing care. So when we think about the guidelines, I'm going to talk to you in different sections. So the first section is talking about screening and early treatment. And one of the first recommendations is to ensure that you have a performance improvement program in place, especially having a screening program for acutely ill, high-risk patients, and also having some standard processes, whether there's standard operating procedures, guidelines, protocols, order sets, something that's uniform in your institution for the treatment of sepsis. One of the new recommendations is related to the Q-SOFA, or the Quick Sequential Organ Failure Assessment. And the recommendation is to do not use the Q-SOFA as a single screening tool for sepsis or septic shock. It may be used and combined with others as far as the early warning systems, but it should not be used as a single screening tool. Also, early treatment, early screening, we should measure blood lactate in patients suspected of having sepsis. We also recognize early treatment is important, and sepsis and septic shock are an emergency, and we need to begin treatment and resuscitation as soon as feasibly possible after recognition. For patients with sepsis-induced hypoperfusion with a lactate of 4 or more, septic shock, we want to give at least 30 mLs per kilogram of IV crystalloid in the first 3 hours. And then we wanted to continue to assess the patient and the responsiveness to this treatment using various measures to guide resuscitation, with one being passive leg raise using dynamic measures. We want to continue to measure the lactate, looking for decreasing lactate to guide our resuscitation. And also new to the guidelines is the use of capillary refill time. Normal is less than 2 seconds. And this is something that's really important from a nursing perspective because it really doesn't require technology. So we can do this fairly quickly as an adjunct to other methods to guide resuscitation. And again, it's important that you look at your protocols in your institution and ensure that the nurses are trained on how to use this process to guide resuscitation. We also want to think about ensuring that our mean arterial pressure is in and around 65. And if the patient's status becomes acutely ill and they require an ICU admission, our goal really is to admit the patient to the ICU within 6 hours. The antimicrobial infection section is a little bit complicated, so I'm not going to address everything, but there are quite a number of recommendations that do apply to nursing. I'm going to focus primarily on antimicrobials and the timing. So if there's an unconfirmed infection and suspected sepsis, we want to continue to evaluate the patient and discontinue antimicrobials if there's another cause for the illness that's identified. In the case where a patient has possible septic shock or a high likelihood of sepsis, we want to give antimicrobials immediately within the first hour of sepsis recognition. For patients with sepsis without shock, we want to assess the patient. If we continue to have a concern that the patient has sepsis, we want to give antimicrobials within 3 hours from the onset of recognition. And again, it's important that we all recognize that 3 hours can go very quickly. So we want to continue to ensure that we're monitoring this patient very closely and administering appropriate therapies. There are several recommendations for patients that are at risk for various types of infections, including MRSA, multi-drug resistant organisms, as well as fungal infections. And again, there are recommendations on how to treat those as well. For patients that initially received a bolus beta-lactam, we want to actually recommend using a prolonged infusion of beta-lactam for maintenance. And this is important from a nursing standpoint because we need to ensure that the patient has IV access capability so that we can deliver that prolonged infusion. In addition to antimicrobials, we really want to address source control. So we want to identify and assess and identify the source of the infection, remove devices, IV devices that potentially could be the source of infection, as well as implement source control interventions. If the patient needs to go to the operating room, needs debridement, needs an intervention, a drain, we want to get that treatment to that patient as soon as feasibly possible. And then after the sources control management is underway, we want to actually look and assess this patient daily to de-escalate antimicrobial treatment. And when we think about hemodynamic management, we primarily are looking at fluids, vasopressors, and how we're monitoring that particular patient. So the fluid of choice, we want to use a balanced crystalloid as a first-line fluid instead of normal saline, for instance, lactated ringers. If the patient's receiving large volumes of crystalloid, if the volumes of crystalloid have been given are very large, you want to consider using albumin, so your provider may order albumin in that particular case. If the patient's not responsive to fluid resuscitation and requires vasopressors, norepinephrine is the first-line vasopressor that we're going to choose. And rather than increasing norepinephrine dose exceedingly, we may want to consider adding vasopressin in that particular case. We want to use arterial blood pressure monitoring for patients with septic shock, so the patient's going to need an A-line. And new to the guidelines this year, 2021 guidelines, is the use of a peripheral line for starting vasopressors. Again, we don't want the patient delay the treatment, so rather than wait for a central venous catheter, we can consider beginning vasopressors using a peripheral line. And again, maybe the patient's only going to be on vasopressors for a short period of time and may never need a central venous catheter. So this option is a good one in this particular situation. Ventilation, there are two new recommendations here. The first being high flow nasal cannula. I know a lot of us in nursing have gained a lot of experience with high flow nasal cannula during COVID, but in the recommendations here, we suggest to use high flow nasal cannula in patients with sepsis-induced hypotoxic respiratory failure rather than non-invasive ventilation. For proning, you want to use prone positioning for greater than 12 hours per day in patients with moderate to severe ARDS. And for neuromuscular blocking agents, it suggests using intermittent boluses over continuous infusions in patients with moderate to severe ARDS. And it's important that you look at your policies and procedures, ensure they're in line with the new sepsis guidelines, and address them as needed as far as education. New also to the guidelines are the use of VV ECMO when conventional ventilation fails. And using VV ECMO requires an experienced center, and nurses have to be trained to support this technology. There are a number of additional therapies, and again, I don't have everything listed on this slide, so please refer to the guidelines for additional information. But here I pulled out what I thought was important for most nurses to know. The first one being steroids, and there's been lots of changes back and forth over the years in steroids, but what to do for patients that have ongoing septic shock requiring vasopressors. You want to administer corticosteroids. However, I recommend against using steroids if you're able to obtain hemodynamic stability using fluids and vasopressors. So the patient's stable with the fluids that you've given them, as well as a vasopressor dose, we would recommend against steroids. Stress ulcer prophylaxis, we want to advocate for patients to receive stress ulcer prophylaxis, prevent GI bleeding, suggest against using mechanical compression devices over pharmacologic therapy. Again, there was a large study that showed that there was not as much benefit, as well as patients complaining of pain and some pressure ulcers in those areas. Glucose control, we want to start insulin therapy if the glucose level is greater than 180 milligrams per deciliter. And also new to the guidelines this year, there's been talk over the past several years about using vitamin C. And based on the literature that has evolved over the years, the last several years, we recommend against using vitamin C for sepsis or septic shock. New to the guidelines is a large section on long-term outcomes and goals of care, and I would recommend that you take a few minutes to review that because there are many recommendations that are specific to nursing, and nursing can make a huge difference in long-term outcomes for patients that have survived sepsis. And with more patients surviving sepsis, we really need to think about long-term outcomes in this population. But on the short term, talking to patients and families about goals of care and prognosis is important, and preferably within the first 72 hours. You also want to provide patients and family the opportunity to participate in shared decision-making, especially when there's transitions of care. Palliative care is important, and not every institution has a palliative care team. But here we're recommending that you integrate the principles of palliative care into the treatment plan to address patient and family symptoms of suffering. Transitions of care is a critical time period where there can be challenges getting appropriate information from one team to another. So here the suggestion is that we use handoff processes of important information for transitions of care. We're not saying you have to use a specific tool, but please have something in place so that important information about the patient's care, especially in the ICU, is provided. We also want to give education, provide written and verbal sepsis education that would include a diagnosis, treatment, and information about post-intensive care syndrome prior to hospital discharge and follow-up. And then we also want to prepare the patient for discharge and follow-up by screening for economic and social support and make referrals as appropriate. Discharge plans should include medication reconciliation, physician follow-up, referral to a peer support group, and further evaluation of PICS and sequelae that the patient developed while they were hospitalized. And again, that's most of this section is new, and I appreciate your time. And I hope you enjoy the rest of your conference. Thank you so much.
Hi, and welcome to the 51st Critical Care Congress. I'm Dr. Marilyn Bullock, and today I'll be providing the pharmacist perspective on the 2021 Surviving Sepsis Campaign guideline implementation. We hope that this session would be an open question-answer forum as we've had in past guidelines, but with the switch to virtual Congress, we've had to alter our delivery. So I want to bring your attention to several pharmacotherapy topics of interest within the guidelines. The first is push-dose pressors, or peripherally administered vasopressors. Now, despite the fact that 15% of our ICU patients have trouble with central lines, this is the first time that the guidelines have really spent any depth at addressing these vasopressors administered peripherally. We know peripheral lines can provide a safe and less invasive access, at least short term. And when used correctly with appropriate monitoring, peripherally administered vasopressors can result in minimal extravasation and little tissue injury. Beyond that, though, the guidelines don't provide a lot of guidance or direction on how to use these push-dose pressors. When you look at the literature and the few protocols that are available, the maximum durations vary widely. But what we do know is that durations less than 24 hours are associated with the least amount of extravasation and complications. We also know that durations longer than 72 hours are not well studied. These really are meant to be a temporary fix. One study using norepinephrine went to suggest that you should not use it any longer than 4 to 6 hours. And that's because over 90% of patients in their study who had extravasation had push-dose pressor durations longer than 6 hours. You also want to keep in mind the practical aspects of how to use these medications. The concentrations used in the studies were standard concentrations, but you want to use the minimum concentration that you can get away with. You also do not want to exceed the maximum doses that we know were safely delivered via this route. You can see these doses here on the left. Now, phenylephrine is a little bit unique in that it's available as a 10 milligram per ml injection that can be given in doses of 40 to 100 micrograms every 1 to 2 minutes, as long as you don't exceed a total of 200 micrograms. Now, this is an on-label use for hypotension during anesthesia, but something that we can probably extract to sepsis if we're careful. The patients that you want to reserve push-dose pressors for mostly resolve around those that you can't get a central line in. Either you can't establish it in the patient or it's just not available at your institution. So it should be reserved primarily for those patients where vasopressors are not going to be needed for an extended duration of time, especially around that 24-hour mark, and only when one vasopressor is required. It's best to develop a protocol or at least a policy on how to use these push-dose pressors safely and effectively. Physicians need to be involved at all aspects of communication and ensure that they are monitoring for efficacy and safety throughout use. Physicians also want to have a plan in place in case their patients do need vasopressors beyond 24 hours. Nurses should be responsible for establishing access, administering the medication, and monitoring diligently for extravasation and tissue injury. Pharmacists should verify that we're using the lowest concentration possible and not exceeding the maximum safe doses of any of these agents. We should also ensure that we're limiting duration to less than 24 hours. Another topic that the guidelines spend a good amount of time on is vasopressor escalation. But what about when our patients get better? They're hemodynamically stable, and it's time to stop some of these vasopressors. To be honest, I was always trained to stop vasopressin first and norepinephrine last. That's what I did for a number of years. But recent literature suggests that this may not be the best practice. Let's look at this study by Song et al. As you can see, in the group where vasopressin was stopped first, those patients developed more hypotension in the first 24 hours and had a higher 28-day mortality compared to when norepinephrine was stopped first. It's important to understand that the group where vasopressin was stopped first did have more steroid use, dialysis use, and were more likely to be at the maximum norepinephrine infusion rate. Still, it's worth noting that when vasopressin was stopped after norepinephrine, those patients had a shorter ICU and hospital length of stay. And there may be several biomolecular and physiological advantages to continuing vasopressor as our patient's shock resolves. We know the natural physiologic use of vasopressin in our bodies, but more information is still noted before we know the exact mechanism behind this. There are other studies that seem to support stopping norepinephrine before vasopressin. When you stop vasopressin first, patients seem to have more hypotension versus when you stop vasopressin after stopping norepinephrine. The studies seem to differ, though, as to whether other outcomes are affected, such as length of stay. But all in all, maybe it's a good time that we switch our practice in order of when we stop vasopressors. The guidelines spend a good amount of time discussing empiric antimicrobial coverage, and that's fair. The infection is what's driving the sepsis after all, and they provide somewhat of a simplified approach on who should get empiric antimicrobial coverage against certain organisms. Looks like if they're at high risk, you should use it, and if they're at low risk, you shouldn't. But it's not that easy. Let's talk about what does make a patient at high risk, and we'll begin with MRSA. If you've had a prior MRSA infection or you have a patient who's colonized, they should get empiric coverage. It's easy to use a nasal swab to screen for colonization. You should also provide empiric coverage in anyone who's had recent antibiotics through the IV route, those with a history of recurrent skin infections or chronic wounds, those with invasive devices or who are on hemodialysis, as well as those who have been recently hospitalized, especially for a longer duration of time, and areas who have a high prevalence of MRSA in their unit. Everyone should receive at least one drug that targets multi-drug resistant pathogens. And in my mind, when I think of this, I'm thinking about Pseudomonas. But not everybody needs double coverage. Only patients who have these risk factors need 2 drugs directed against Pseudomonas. So this includes those who have a proven infection with a multi-drug resistant pathogen or who are colonized with an organism in the preceding year. If you live in an area that has a high prevalence of resistant organisms, or you have a patient with a nosocomial infection, they should receive 2 drugs. If you have patients who've had broad spectrum antibiotic use within the past 90 days, who are receiving selective digestive decontamination, or who have traveled to a highly endemic area within the past 90 days, they should also receive double coverage. Finally, anyone who's been hospitalized outside of our country within the past 90 days qualifies. It's a very narrow list, and it doesn't encompass as many patients that actually receive double coverage. And finally, we can't forget about fungal infections. Many of patients have host factors that would qualify them for receiving them. But if you have a patient who's not getting better, their fever is not going away after 4 to 7 days of what should be appropriate broad spectrum antibiotics, you want to consider fungal coverage. It should also be considered anyone with a prior fungal infection or colonization, those who've had prior exposure to antifungals recently, people who are immunosuppressed, who are neutropenic, patients with certain comorbidities like diabetes, particularly if they're not getting better because they have an impaired immune system, patients receiving TPN, and anyone who's had a GI perforation. The guidelines discuss at depth using pharmacokinetic and pharmacodynamic factors to achieve optimal bactericidal activity. But it's not just the parameters that help us dose vancomycin and aminoglycoside. You need to consider things with the post-antibiotic effect. Agents that alter protein or nucleic acid synthesis, such as aminoglycosides or fluoroquinolones, display a prolonged post-antibiotic effect against any susceptible organism. And that's because it takes so much longer for bacteria to regenerate these elements compared to cell wall components. Therefore, longer intervals between doses are possible without compromising treatment efficacy. On the other hand, beta-lactams have essentially no post-antibiotic effect, particularly against gram-negatives. And that's why they often require multiple daily doses. The only exception to this is carbapenems, which have a 2 to 4 hour post-antibiotic effect against gram-negatives, but they still require multiple daily doses. To deal with this, for a number of years, we've been using prolonged beta-lactam infusions, which help us maintain blood concentrations that exceed the MIC that's required for optimal bactericidal activity. It's important to initiate this with a loading dose. It's typically the dose that's used in intermittent dosing before you begin the prolonged infusion. Unfortunately, it can be limited in its use. If you have a patient who has limited IV access or has incompatible drugs, or using a drug with limited stability, it can be difficult to use these. As a pharmacist, I tend to always think about the science behind the drugs and how it affects the medication use. In sepsis, many of our patients have physical derangements, and pretty much all of them have had a lot of fluid resuscitation, which could increase the volume and distribution of antimicrobials, particularly those that are hydrophilic. These drugs that are hydrophilic may require loading doses for optimal activity. Thankfully, most of our antibiotics are not affected by low albumin, but a few are, like ceftriaxone and ertapenem. And when you have hypoalbuminemia, it can increase the unbound drug, which subsequently can increase the volume and distribution and antimicrobial clearance. All of this can lead to lower or at least suboptimal concentrations towards the end of the dosing interval. Finally, many of our drugs are cleared renally, and aggressive fluid resuscitation and vasopressor use can augment renal clearance. This may potentially, though not always, result in treatment failure. I also think it's important to remember that just because a drug covers a pathogen doesn't mean it gets into the tissue where the infection actually is. And while antimicrobial coverage, understanding it's important, tissue penetration can be just as key. You should also remember that MICs highly influence dosing and how we use our antibiotics. Once daily aminoglycosides are more in vogue because they achieve a higher Cmax to MIC and AUC to MIC ratio. All of that results in better clinical efficacy and lower nephrotoxicity. Fluoroquinolones may require lower than normal breakpoints that our normal labs use in order to achieve optimal AUC to MIC ratios that are required for maximal bactericidal effects. You may need to discuss with your lab about how they report these to you. The minimum vancomycin trough, if your institution is still collecting troughs, should be 15. That's the trough that's required to achieve the target AUC to MIC ratio of 400 for pathogens with an MIC of 1. And to leave you today, just something to remember, the guidelines discuss using therapeutic drug monitoring for antimicrobials. Well, this is a great idea, especially where it's in place, particularly with aminoglycosides and vancomycin. It's not available or even practical at the average institution for certain antibiotics like beta-lactams and fluoroquinolones. Maybe one day in the future it will be, but at this point, it's just important for you to remember the pharmacokinetic and pharmacodynamic properties of the drugs so you know how to best dose them and use them. Thank you for coming today. I hope you have found some of these pearls helpful as you go back to your institution and implement the 2021 Surviving Sepsis Guidelines. Have a wonderful day.
Hi, everyone. I'm Hallie Prescott, and it's my pleasure to be speaking on Surviving Sepsis Campaign guideline implementation. I have no financial conflicts of interest. I served as the vice chair of the 2021 Surviving Sepsis Campaign guideline and also serve as the physician lead for the Hospital Medicine Safety, or HMS, Sepsis Initiative, which is a Michigan statewide sepsis quality improvement program that's sponsored by Blue Cross Blue Shield of Michigan. Finally, I'm just obliged to tell you, this talk does not necessarily represent views of my employers, the US government, or the Department of Veteran Affairs. So for today's talk, I have two primary objectives. I'd like to introduce you to HMS Sepsis, the Michigan Statewide Sepsis Initiative, and then talk specifically about how HMS is using or leveraging the Surviving Sepsis Campaign guidelines to really scaffold and drive all of our performance improvement activities. So first, a little bit of background. The Sepsis Initiative lives within the Hospital Medicine Safety Collaborative Quality Initiative, which is one of about 20 CQIs that are sponsored by Blue Cross Blue Shield of Michigan through their Value Partnerships program. Essentially, these are programs that they run that are moving us away from fee-for-service medical care to paying for better quality and outcomes. The general structure of these CQIs is that Blue Cross Blue Shield funds the coordinating centers as well as the participating hospitals. So they provide support for the data collection as well as the QI efforts. The coordinating center serves as the data warehouse, generates the feedback reports, sets performance targets, and convenes meetings 3 times a year. The hospitals submit their data, receive their feedback reports, implement local quality improvement work, share challenges and successes at our 3 times yearly collaborative wide meetings. So there's several elements of these CQIs that I think are really integral to their success. First of all, these are led by clinicians. These aren't things that are sort of descending from above, but really Blue Cross is empowering clinicians to lead this work across the state. We have robust data registries. So we collect really detailed, sort of granular, nuanced clinical information, which is useful for determining, that the patient really is eligible for the performance measure and being able to calculate risk-adjusted outcomes. We set rigorous performance targets because we have data for sepsis care and outcomes across the state. We're able to set performance targets that are a nudge or a stretch, but aren't totally infeasible and likewise aren't too easy, but do provide a challenge to our hospitals. We have support from Blue Cross Blue Shield, without which we would not be able to do all the work that we do. And there's a strong incentive for hospitals to participate because ultimately the performance index influences the payments that hospitals receive. And then finally, there's a strong element of networking and collaboration through the 3 times yearly collaborative wide meetings, such that we really can share our experiences and learn from the other hospitals across the state of Michigan. So the Hospital Medicine Safety Consortium was launched in 2010 and broadly has a goal to improve the care of hospitalized medical patients. As of this year, we have 69 hospitals participating, which really represent a diverse group of hospitals across our state and almost all of our larger hospitals. There have been 5 initiatives to date: venous thromboembolism, PIC and midline appropriateness, antimicrobial use and stewardship, COVID-19, and most recently, sepsis. So I'll talk a little bit about how hospitalizations for sepsis get identified for inclusion into our cohort and our performance evaluation. We have a 2-step process. First, we pull in potentially eligible hospitalizations that have a discharge diagnosis that's plausibly consistent with sepsis. But then all of those hospitals go through a screening process where we ensure that there is objective evidence of infection and acute organ dysfunction present early on in that hospitalization, such that there's a consistent threshold for who gets labeled as sepsis in our initiative, recognizing that the diagnosis and coding of sepsis has varied over time and across hospitals. We ensure that there is a consistent threshold of who gets into our initiative. We then stratify these hospitalizations as sepsis versus septic shock based on just the data from the first hour to 2 hours of hospitalization. Did they present with sepsis or did they present with septic shock? Once hospitalizations are included into our cohort, we then abstract data to be able to measure care processes, risk-adjusted outcomes, and then eventually to evaluate performance measures that go into our performance index and impact payment. So I'll talk a little bit about the reports that we provide back to hospitals. We have a hospital-specific report that goes through the care and outcomes of sepsis at that hospital. And then we have a collaborative-wide comparison that compares outcomes at that hospital to all the other hospitals in our collaborative. And here we really use the Surviving Sepsis Campaign guidelines to determine which care processes to include in our reports, and in particular, which of those care processes have enough evidence behind them, are strongly recommended such that we can then include them into our performance index. So I'll walk you through some of the bundles that we collect. We have an early sepsis bundle, and many of the elements in this bundle will be familiar to you. This is measurement of lactate, remeasurement if elevated, collection of blood culture and doing so before the antibiotics are delivered, giving antibiotics in a timely fashion, and then giving fluid resuscitation when indicated. Each of these elements really comes directly from the Surviving Sepsis Campaign guidelines. And one of the more recent changes that we made to this early sepsis bundle was to stratify our timing targets for antibiotics based on whether the patient presents with sepsis or septic shock, hypotension. So the new recommendations in the 2021 guidelines say that when you're not sure the patient may have sepsis and they are not in shock, that there is now a recommendation for a rapid assessment of infectious versus non-infectious causes of illness with a goal to administer antibiotics within 3 hours if concern for infection still persists. So we have relaxed or extended the timing threshold for patients who present initially with sepsis, again, in concordance with these updated recommendations from the 2021 guideline. So here is a snapshot from a recent performance report. And you can see that the eligible patients, the denominator here varies across each of these elements. And that's, again, sort of where we use this granular clinical information to determine who's eligible for each of these measures. And then we use the Surviving Sepsis Campaign guideline, as I mentioned, to determine which of these have stronger levels of evidence, have stronger recommendations in the guideline. These are things that we think down the road may end up in our performance index. And so the ones that we are focusing on right now are the collection of blood cultures prior to administration of antibiotics and then timely delivery of antibiotics. For these particular elements of focus, we provide hospitals with more information to try to understand their performance, where the gaps may lie, what solutions may be feasible. So, for example, we provide more information about the timing of blood cultures relative to antibiotics. Did they just miss the mark, or did blood cultures get left off altogether? In terms of delivery of antibiotics, was the lag in the time to order or the time from order to administration? Those different sort of steps would recommend different potential solutions to reduce time to antibiotics in patients. Beyond this early sepsis bundle, we have additional bundles. So here, this is an additional sepsis elements that also get at the early treatment and resuscitation. Many of these, again, come directly out of the Surviving Sepsis Campaign guidelines. Use of norepinephrine as the first-line vasopressor. Use of adjunctive steroids in patients with vasopressor-dependent septic shock. Use of balanced solutions over saline. Lung protective ventilation strategy used. And then some of these measures are, again, trying to look at these processes in a slightly different way. We had in our early sepsis bundle the delivery of 30 ml per kg fluid bolus among patients with hypotension and elevated lactate. And we're seeing that the use of that fluid resuscitation is low. And there's always a challenge. Again, we are sort of coming after the fact to know who was eligible. Maybe it was only a very transient hypotension. We don't have full, complete data like the bedside clinician has. So we're looking at this in a slightly different way with this measure, looking at among patients who get treated with vasopressors, did those patients get 30 ml per kg fluid bolus prior to initiation of vasopressors or shortly thereafter, which is sort of another way of looking at, are we giving fluid resuscitation when indicated? Finally, we have a recovery-based sepsis bundle, and this is really meant to help implement the brand new section of the Surviving Sepsis Campaign guideline on long-term outcomes. And this is recognizing that many of our patients now survive sepsis, but go on to experience poor long-term outcomes, high rates of hospital readmission. And so the guidelines now include a brand new section addressing this issue and providing guidance about how do we enhance recovery through our peri-discharge and post-hospital practices. And there's 3 practices that we are focusing on, particularly in HMS sepsis, and that is medication reconciliation. So we're looking at discrepancies between what people arrived on and what they leave on, focusing on certain medications of interest, sort of evidence-based medications for heart failure, looking to see whether those are maybe unintentionally discontinued, and then looking at new starts of things like opioids, antipsychotics, benzodiazepines that we think should be rare. Next, we look at whether care goals and prognosis, there's documentation that those were discussed during hospitalization. And then finally, we're looking at the scheduling of follow-up prior to discharge, as well as having a contact person to get in touch with to ask questions about the sepsis hospitalization after discharge. And this is meant to be implementing the recommendation that sepsis survivors should have assessment and follow-up for physical, cognitive, emotional problems that are common after sepsis hospitalization. So I am coming up against time. So in conclusion, I have introduced you to the HMS Sepsis Initiative and shown how the Surviving Sepsis Campaign guidelines are really integral to the work that we are doing in the state of Michigan, have helped us to prioritize the measures to focus on and also stratify them to be what are the most important elements that can be used in our performance index. So I will close there, and I'm happy to take questions during the question and answer session. Thanks so much.